Hi, good evening, and welcome back to this series of live sessions on the DocTutorials app. We were discussing about the important long essays asked in your university exam, and continuing with the same, today we'll take up one more important topic, that is the extraocular muscles. From the region of head and neck, as we have discussed, the most frequently asked long essay would be parotid. Apart from parotid, we have the anatomy of dural venous sinuses, then muscles of mastication, TMJ, tongue, palate, larynx, pharynx. One more important topic that is like very frequently asked, and sorry, is like examiner's favorite topic when they set papers is the extraocular muscles. Not just the long essay, but you will also get questions as short essay. You will also get questions as MCQs based on the innervation of extraocular muscles as well as the actions of extraocular muscles, right? Let's try and dissect this whole topic, and let's learn about the detailed anatomy of extraocular muscles, and we will also learn, if this is asked in university exam, how to go about answering this. Invariably, the question will be classify extraocular muscles, explain the extraocular muscles under the following headings, right? The headings could be attachments, innervation, actions, right? So let's try and learn about how to go about answering if this is asked as a long essay, right? So first thing, let's start with classification, right? How do we classify extraocular muscles? Extraocular muscles are classified as voluntary muscles and involuntary muscles. Either you can write like this, or you can do it in the form of a flow chart, right? Even that is good enough, right? For example, so we can write it as classification as extraocular muscles and intraocular muscles. Even this is fine, right? Whichever suits you, do it. Now, what about voluntary muscles? Remember, voluntary muscles can be further grouped as those muscles which actually move the eyeball. When you want to look up, down, laterally, medially, these muscles help in the movement of the eyeball, right? So these are the muscles which actually help move the eyeball. Then the second one is, once we can close the eyelids by the action of orbicularis oculi, if you want to open it, this is the action of a muscle which acts on the eyelid. So let's try to list out these muscles first. So muscles moving the eyeball, what are the muscles? So we have four recti, which are superior, then we have inferior, then we have medial and lateral, then we have two obliques, right? So these obliques are named as the superior oblique and the inferior oblique. So all these muscles will move the eyeball, right? And these are voluntary because we can control the action. There is one muscle which will move the upper eyelid. So muscle moving the upper eyelid, what do we call it as? We call it as the levator. Levator means elevation of the eyelid. Levator, then palpebrae, right? Levator, palpebrae, superioris. Okay. This would be the name of the muscle which will move the upper eyelid. Done? Right. So apart from this, the eyeball also has few muscles which are involuntary, which we cannot control, right? And these are smooth muscles, and these smooth muscles are, one is we have the superior tarsal. Again, these muscles, remember, are present within the eyelids, right? So superior tarsal, which is also referred to as the Muller's muscle, right? Just a minute. Yeah. So this is called as the Muller's muscle. Then the next one we have is the inferior tarsal muscle. Then the third muscle we have is the orbitalis. So these are the three involuntary or smooth muscles that we have. in the eyeball. So this is regarding the classification. So totally remember 10 muscles, 7 voluntary, 3 involuntary. Out of 7 voluntary, we have 6 muscles which act on the eyeball, 1 acting on the eyelid. 3 muscles are smooth muscles. So muscles acting on the eyeball. These are superior, inferior, medial and lateral rectus, superior oblique, inferior oblique. And muscle acting on the eyelid, levator palpebrae superioris. Once we have learned it, let's talk about the attachments. First, let's start with the recti. Remember, all 4 recti, they have a common origin. All of them take their origin from the tendinous ring of Zinn, the common tendinous ring of Zinn. Right? This is the common origin for all recti. So you don't have to remember individual muscles. Now, this origin of these recti muscles, right? They surround the optic nerve. Done? Right. Where to get this? You can skip, but this is a must. Right? Done. What about insertion? Remember, all recti are inserted into the sclera. Right? Again, this is the only thing you need to mention. This is inserted to sclera of the eyeball anterior to the equator of the eyeball. Right? Anterior to equator of the eyeball. These two again are a must and the points which need to be highlighted. Every time the examiner will check for attachments, he will check whether have you mentioned the recti get inserted in front of the equator and oblique gets inserted behind the equator. This is the first thing they will ask. Okay, right. Now, if I just draw the superior surface of the eyeball, okay, so let's imagine this is the outline of the cornea we have. Then this is the eyeball that we are looking at, right? And let's imagine we have the optic nerve here, right? So the equator divides the eyeball into an anterior half. Let's imagine this is the cornea. Now, remember, all recti will get attached here. All obliques will get attached here. So this is recti, this is obliques. Okay. This is the main reason why recti have the same action as their names, whereas the obliques have opposite action. We will see how. Now, so all recti are inserted into sclera close to the limbus. Close to the limbus of the eyeball. And what do we mean by limbus? Limbus refers to the sclerocorneal junction. Right? Done. Now, each of these 4 recti are arranged in such a peculiar way. Let's imagine this is the eyeball and here we have the pupil the cornea, right? So here we have the limbus. Now, let's imagine this side we have the nose. Done. So we have the attachment of the medial rectus, the inferior rectus, the lateral rectus and the superior rectus. So medial, inferior, lateral and superior rectus. These are attached at a clear distance between the limbus and the sclera. So what is it? So remember, this is in a clockwise direction. So 5 millimeters, 6, 7 and 8 millimeters. Can you remember this? This is how we have the attachment of recti in front of the equator at a standard distance from the sclerocorneal junction. So remember, medial rectus at 5 millimeters, inferior 6, lateral 7, superior 8. So we are going in the clockwise direction. This is regarding the attachment of recti. The attachment of obliques is slightly different. We have 2 obliques that we need to remember, and both the obliques have a peculiar origin. The insertion is almost the same. Right. Now, what about the origin of superior oblique? The superior oblique takes its origin from the roof of the orbit, whereas inferior oblique takes its origin from the floor of the orbit. If you can write this, nothing like it. Or otherwise, you can specify that this takes its origin from the sphenoid and this takes its origin from the maxilla, orbital plate. Even if you can't remember it specifically, at least mention one arises from the roof and the other arises from the floor. Right? The special feature of superior oblique muscle is it passes through a structure called as trochlea, which is present right in the roof of the orbit. The tendon turns back into the orbit by passing through this hook. Right? Done. Where does it get inserted? Remember, the insertion is again into sclera. Even this is into sclera. So both the muscles will get ultimately inserted into sclera, just similar to your recti. But what is the peculiarity that we need to highlight? This inserts behind the equator, whereas the sclera, the inferior oblique also gets inserted behind the equator, right? Usually into the posterior superior quadrant, the posterior superior quadrant. Imagine your eyeball is like this. The superior oblique, what it does is it passes in front of the eyeball, goes back and gets inserted behind the equator. The inferior oblique arises from the floor and then gets inserted to the posterior superior quadrant, right? This is one of the reasons why the muscles actually bring about opposite actions to their names, superior and inferior oblique, right? Done. The next thing we have is the levator palpebrae superioris, right? As the name suggests, this is the elevator of the eyelid, which is situated in the upper part. Fine. So remember the levator palpebrae superioris, right? This muscle arises from the skin, gets inserted to the tarsal plates of the eyeball, right? Bringing about the elevation of the eyelid. Apart from this, remember, levator palpebrae superioris gives rise to the superior tarsal muscle as well, right? Part of the attachment of levator palpebrae superioris gets detached. The insertion of the levator palpebrae superioris is divided into superior lamella, middle, and inferior lamella. One of these lamella will actually give rise to the superior tarsal muscle, right? Done. Then, what about the innervation? In innervation, all we need to remember is the rule LR6, SO4, and rest by 3. What do we mean by this? LR refers to lateral rectus, 6 refers to abducent nerve. So lateral rectus is supplied by the abducens nerve, right? Then SO4, what does this mean? Superior oblique, remember, this is supplied by the trochlear nerve. Are we clear? Right. What about the other? All others are supplied by the oculomotor nerve, right? Which is the third cranial nerve. Now, there is nothing wrong in writing this mnemonic as well in your exam because it will be easier for you to recall. Then, once you write it, you can summarize the innervation like this. Even levator palpebrae superioris is innervated by the oculomotor nerve. Are we clear? So this is how we must mention about the innervation. What about the smooth muscle component? The smooth muscle component will be also innervated by the autonomic nerves. This will be innervated by the autonomic nerves. The superior tarsal, the inferior tarsal, and the orbitalis. To be more specific, These will be innervated by the superior cervical ganglion. Done? Are we clear? Fibers of T1. This supplies these smooth muscles. Done. Innervation, you must remember this mnemonic: LR6, SO4, and rest by 3. Now, what about actions of extraocular muscles? The actions of extraocular muscles is easy to remember if you can practice the diagram that we are writing now. Okay, so let's imagine we have the eyeball. Let's imagine this is the nose, right? So we will learn about actions of each of these recti first, and then we'll go for obliques. So first, let's talk about the medial rectus itself. The medial rectus muscle brings about, this is, imagine, medial rectus. Now, what will you call the movement where part of the body moved towards the midline? Yes, it is adduction. So what is the primary action of medial rectus? The only action it can ever bring about is adduction, nothing else. Then, what about lateral rectus? Lateral rectus can also bring about only one action. We'll do it again. So this is lateral rectus. So lateral rectus can bring about what action? It can bring about abduction. So medial rectus adduction, lateral rectus abduction. Now, how about the superior rectus and the inferior rectus? Remember, the superior rectus will bring about the upward movement of the eyeball. So what is this upward movement? We refer it to as elevation. But apart from this, remember, the superior rectus can also bring about adduction and rotation of the eyeball towards the nose, which is referred to as intorsion. So elevation, then adduction, and then what? The intorsion. Are we clear? Now, what about inferior rectus? Inferior rectus brings about, this is the inferior rectus. What is this action? This is depression. Inferior rectus brings about depression. Then it brings about, what is this action? Sorry. This is again bringing about adduction, right? So brings about adduction and then rotate the eyeball away from the nose. This is what we call as extorsion. Now, if you learn this diagram, nothing like it. Okay, you can redraw the extraocular muscles action anywhere. You don't have to mug it up. Then, what about obliques? So let's talk about obliques. Obliques are very peculiar. The obliques have exactly the opposite action. For example, depression of the eyeball is brought about by the superior oblique. Okay, superior oblique. So what is the action of superior oblique? It brings about depression. Are we clear? This is why I said they have opposite actions of recti. Then it can bring about, what is this movement? This movement is abduction. Then it can rotate the eyeball towards the nose, tip of the nose, right? So what is this action? This is intorsion. Then what about inferior oblique? Inferior oblique should cause what? Elevation, then abduction, extorsion. So elevation, here it is abduction and it is extortion. Are we clear? This is what we call as Starling's diagram. If you learn how to draw this diagram, you have mastered the actions of the extraocular muscles. Remember, extraocular muscle actions sometimes can be given more weightage, right? Nerve supply may be 2 marks, but they may keep a lot of marks for actions. And if you draw this diagram, nothing like it. Okay, done. Levator palpebrae superioris has only one action, and what is that? This is elevation of the eyeball. Sorry, elevation of eyelid. And which eyelid? The upper eyelid. Right? Are we clear? So this is regarding the actions of all the seven voluntary muscles. Involuntary muscles, even if you don't describe the actions, attachments, it's still fine. But voluntary muscles, you must mention the attachments, you must mention the nerve supply, as well as you must mention its actions as well. Done. Now, what happens if these muscles get paralyzed? Lateral rectus muscle, what is the action? Lateral rectus brings about abduction of the eyeball. If lateral rectus is paralyzed, what it will result in? It will result in uncontrolled movement of the eyeball towards the nose. What do we call it as? This we call it as loss of abduction, and this can lead to medial squint. So lateral rectus palsy can lead to medial squint, and medial rectus palsy can lead to lateral squint. Okay. Superior oblique palsy leads to a very peculiar condition called as diplopia, which is also referred to as double vision on looking downwards. So whenever the person tries to look downwards, he will see one object as two. This is what we call as diplopia, right? This is a characteristic feature of superior oblique palsy. Now, if oculomotor nerve is paralyzed, remember, this leads to paralysis of what muscles? The superior rectus, medial rectus, inferior rectus, inferior oblique, and levator palpebrae superioris. Okay, so this usually presents as one important clinical condition, which is ptosis. Then we can have constriction of pupil, which is also called as meiosis. This is the clinical feature which is seen in oculomotor nerve palsy. If you remember the action of the muscles, you can always write the clinical correlation. What movement is lost, what type of squint occurs, this you can write. Okay, so this is how you must explain the clinical correlation of the extraocular muscles if it is asked as a long essay. So remember, start with the classification, mention about the attachments of recti and obliques separately, mention about the attachments of LPS, then talk about innervation where you mention about the mnemonic, then draw the diagram to demonstrate or write the actions of extraocular muscles. Remember, it is difficult to mug up the actions. Learn this diagram, draw as many times as you can. Not a very difficult diagram. Possibly the easiest diagram you can draw in anatomy. Right? Done. And then oblique muscles action. End it up with the clinical correlation of the extraocular muscles. 25 minutes. This, if you can write, I can assure you that you will get at least 9 out of 10. Right? So this is regarding the extraocular muscles. So we are done with one more important long essay for your exam. Coming week, we'll take up one more important topic for your university exam. If you have any topic in mind, please do let me know. We shall discuss the same. Otherwise, we will discuss about important histology slides this Thursday again. Last week, remember, we discussed about three blood vessels. This week, we'll try to complete the discussion by discussing about the anatomy of, I think we discussed about lymphatic tissue, we discussed about blood vessels, we discussed about nervous tissue, cartilage we have discussed. Let's try and learn, Nick, this week about the histology of skin. We will discuss the histology of thick skin and thin skin using those H&D stain slides. Right? If you have any doubt, please let me know. Before we close, I shall try and clear these doubts. Right. If there are no doubts, thank you very much for joining. We will join again this Thursday and discuss about the histology of